Jugular groove. In the mid-third of the face, facial aging involves a loss of convexity. Different factors during aging result in the appearance of a depression called the mid-jugal groove. These factors are due to fat, muscle and the septum, and the main factors include the superficial adipose compartment of the nasolabial fold, which does not lose significant volume, the superficial mesial adipose compartments, mid-cheek and deep suborbital, whose fat loss contributes to the appearance of the mid-jugal groove, the orbicular muscle, whose lower edge laterally borders the mid-jugal groove, and lastly, the malar septum, which separates the medial and lateral slopes from this mid-jugal depression. The mid-jugal groove is an anatomical extension, lower and to the outside of the nasojugal groove or tear trough, without the same anatomical etiology. The main anatomic precautions for injecting the mid-jugal region involve the infraorbital artery and the intraorbital nerve, a sensory nerve that starts in the infraorbital foramen of the maxillary bone. Convexity of the mid-third of the face extends to the nasolabial fold below and in front, to the zygomatic arch above and to the back. This full crescent flattens and then becomes concave at its midpoint, highlighting the mid-jugal groove, commonly called the tear trough. Just like with the nasolabial fold, the tear trough has a constant upper end of the nasojugal groove or mid-part of the eye ring, and a variable lower end, depending on physiognomy. Several insertion points are possible for injecting the mid-jugal fold and the associated loss of centrofacial volume. Injections are done throughout the depression area using the fanning technique. The fan extends over the lateral nasal region to the malar eminence while respecting the lower limit of the eye ring. Several fans can be combined. Injections can also be made using adjacent bolus techniques, the pillar technique, when volume loss requires greater projection. The main bolus meets the middle of the tear trough depression, and contiguous boluses are set up based on the physiognomy of the area being treated to ensure harmonious matching with the cheekbone at the back and the lateronasal region at the front. After disinfecting, make a pre-hole with a needle to the dermic-hypodermic junction and insert the cannula parallel to the cutaneous plane in the desired injection plane. Make the retrotracing injection by removing the syringe to obtain a linear and homogeneous Radiesse deposit. Without removing the end of the cannula from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. Massage and shape the areas injected to evenly spread the product. With Radiesse, the product deposit and correlated correction are assessed immediately. Several fans can be combined, ending with a netting or grid technique if volume restoration requires it. The tear trough can also be injected using a needle by these same techniques or on adjacent bolus techniques, the pillar technique, when volume loss requires greater projection.